So for our next lecture, I'm very proud to present and ask you to give a very warm welcome to Dr. Judith Barbaro-Brown.
Lovely. Thank you, Olga. I'm very, very happy to be asked back. It's nice to actually be at a live event, and I'm sure you're probably all excited to be at a live event as well. We've spent the last few years living on Zoom and Teams, and I don't know about you, but I like to speak to people face to face, so this is really nice to actually see real people in a real room for once, so it's great to be asked. Thank you, Olga. So, in this session, as you can see from the title, we're going to look at a whole range of things which can cause neuropathy in our patients. Now, because this is such a vast subject that we could talk for weeks and weeks about it, obviously we haven't got time for all that, so what I'm going to do is do it as an overview and then use one or two things as examples of specific types of neuropathy. So I'll choose something from each of the kind of the main causative factor groups, and that's how we'll do it. So we're going to cover a lot of stuff, not in a huge amount of depth, but we'll kind of make sure that we cover the main things that we need to cover. Obviously, if you have any questions, please, feel free to ask them at the end. Hopefully, this will be useful. I suspect a lot of it will be kind of revision for you, really, and there may be one or two things that perhaps you weren't aware of, but hopefully we're just going to consolidate everything that you already know. So fingers crossed for that. Okay, so let me press the button, we'll get started. So we all know that neuropathy is just a cover term, and it basically means anything that interferes with the function of a nerve or anything in your nervous system, either your central nervous system or your peripheral nervous system. So anything that interferes with function. And we know that nerves are involved in movement and motor functions. Nerves are involved in sensation, but they're also very important in your autonomic system as well for managing all those things that your body does without you having to think about it, all right? So your nerves basically control just about everything in your body, together with your hormones as well, but we're not really going to talk much about hormones today. So anything that interferes with the function of a nerve, we can class as a cause of neuropathy, okay? And any loss of function in a nerve, whether it's sensory, motor, or autonomic, is a neuropathy. So it is just a blanket term, and it can be due to multiple different factors. There are all sorts of factors that can cause it. Commonly it can be an underlying pathology like diabetes, so it could be something to do with your glucose levels. It could be traumatic, so you could have had an accident and actually physically damaged the nerve. It could be, a very, very common one is compression. So, it could be compression occurring on a nerve because of a pathology, because of trauma, even something as simple as clothing. And I learned this very, very early on in my career when I worked in the NHS, and I had a lady come in, and she was complaining that her whole foot was numb, but just one foot, and I couldn't really find any cause. So I thought, this is really, really weird, and I'm a bit concerned because this is a really dense neuropathy, and the other legs are kind of, early on in my career, when you kind of think the worst of everything and everybody's got a tumour or whatever, you forget that common things are common and rare things are rare. And so I said, I'll just go and chat with the GP about the best thing to do. And I went, knocked on the GP's door, who's a lovely man, and he said, well, I better come along and have a look. So he came and he had a look. He took off her elastic stocking, and the sensation came back. And I thought, you idiot. Duh. And so it's very, very easy for these things to happen. But it just goes to show that you can be caught out around these things, and I was definitely caught out. The doctor just laughed and went away, and the patient looked at me as if to say, God, you're thick. So it can happen. But other things can be, ischemia is a perfect example of why you can get neuropathy, and it was ischemia that was being caused by this lady's elastic stocking, oddly enough, which she was wearing to manage her varicose veins. So, there's a tale to tell there as well. But it can be also to do with, dietary deficiencies. So if you're deficient in certain vitamins, that could be problematic as well. There could be a genetic problem. There could be some kind of genetic disorder that's causing a change in nerve function. you know, even things like arthritis, osteoarthritis, it can be all sorts of things. So, you know, quite frequently we don't even know what the cause is, you know, so there can be an idiopathic reason, and that simply means we don't know what's causing this. So we're just going to give it a different name, right? So it can be a whole range of things that cause neuropathy. But just to remind ourselves about the system, remember the system that we're looking at, your neurological system. So divided into your central nervous system, which is your brain and your spinal cord, and then your peripheral nervous system, which is everything that leaves the spinal cord and goes to the rest of your body, okay? And in your peripheral system, it's divided into your autonomic side, which controls all those functions that you don't have to think about. And then you've got what we call the somatic side, and that's the side that is movement, sensation, etc. I put an extra little box on this because a lot of people forget also that your gut is also controlled by your autonomic nervous system, but it's a separate system within that, which we call your enteric system. You don't need to think too much about it, but just be aware that there is actually a separate system in that, and it can cause problems if you've got neuropathy in there with gut movement and gut function. And then your autonomic system is further divided into the sympathetic and the parasympathetic. So your sympathetic system is there to speed things up, to get you going with things. You know, it's the kind of the help you run away from danger system. And you've got the parasympathetic system, which is, you know, what kind of calms everything down and keeps things going and keeps things running. So as you're sitting here, your parasympathetic system will be thinking about managing the coffee and the tea that you've just eaten or the pastries. If the alarm goes off, if the fire alarm goes off, your sympathetic system will kick in and we'll all run out the door. Right? So that's how it works together. Okay, so just a quick bit of revision. More importantly is remembering what the nerves look like. So that's kind of a classical representation of a nerve cell, okay, or a neuron. And at one end, we've got the cell body, which has the nucleus in. And at the other end, we have the synaptic membrane, the synapse end, which is what basically synapses with another nerve cell. And connecting the two is the very, very long axon. And that's usually surrounded by a type of cell called a Schwann cell, which is where all the myelin sits. And some neurons have more myelin than others, and it will depend on what that neuron does. So some neurons which are involved in very vegetative functions, like in your digestion, that doesn't have a lot of myelin. Okay, doesn't need to have a fast conduction pathway, but anything that needs fast conduction has lots of myelin because it really speeds up the rate that the nerve impulse moves along the nerve. So the more myelin it has, the faster that nerve will conduct. All right, so what else do we need to say? Not a huge amount, but I just want you to remember this here, okay, this diagram here. So remember, Schwann cells, they contain the myelin, and the myelin's wrapped around the axon and forms a really dense insulatory structure around the axon, and it just leaves little bits of the axon exposed between the Schwann cells, so the action potential, the nerve impulse, can jump from there to the next one, to the next one, to the next one, and that makes a really fast speed of conduction. Okay, so it's important to remember what the myelin's doing, and we'll need that for a bit later on. Something else to think about, and again, if we're thinking about peripheral neuropathy in the lower limb, important to kind of remember this, is remember how your spinal cord is arranged in your vertebral column, all right? So obviously your spinal cord runs down from your brain. Your spinal cord actually ends at the level of your second lumbar vertebrae, so it ends about 2/3 of the way down your back. And then the rest of the nerves that leave the spinal column, the spinal cord, kind of just form this bundle of spinal nerves, which are called the cauda equina, meaning horsetail, and they kind of sit within this sac that surrounds the whole spinal cord. They sit in that sac and they exit the sac at different levels. So the spinal nerves are exiting the spinal column all the way down, all right? Spinal column itself ends at L2, and then the nerves just trail down inside the sac that surrounds everything, and then they also exit at different levels too. So we know that at each vertebral level, we get a pair of spinal nerves exiting, okay? Bear in mind that the level that they exit the vertebral column is not always the level they exit the spinal column. So you can have nerves that exit the spinal column quite high up, but don't actually leave the vertebral column till much, much lower down. And that's sometimes why when you get spinal column damage high up, it will still affect nerves that leave lower down because they've already exited the spinal column at that level, if that makes sense. Okay? So it doesn't always fit, it doesn't always follow that if you damage the vertebral column at a certain point, that the nerves exiting at that point didn't exit. The nerves exiting at that point didn't exit the spinal column at that point as well. Okay, so they can leave higher up and not exit the spinal cord. God, get your words right, Judith. The vertebral column further down. Okay, so the last thing I want to look at kind of revision-wise is, so here's a really nice picture of what your actual cauda equina looks like. So if we go to the top, that's about the level of L2. That's the end of your spinal cord. And then everything down there, they are all spinal nerves that are just sitting in that space, ready to exit. Okay, and they exit between the vertebral bodies in the what we call the intervertebral foramen, that space between the vertebrae, and they exit looking like this. Okay, so each spinal nerve is quite big, all right, and it contains nerves that are responsible for motor function, sensory function, and autonomic function. So we call these mixed nerves. They've got everything in there. And then once they leave the vertebral column, they will then split. They will then separate, and eventually the motor nerves will be separate, the sensory nerves will be separate, and the autonomic nerves will be separate, and they will then go to all sorts of different areas and do what they're meant to do. But when things leave the spinal column and the vertebral column, they are single nerves at that level, and they contain multiple mixed fibers. Okay, but they are quite big. All right, certainly down at the lower level, it's not unusual for the spinal nerves to be as thick as a standard pencil. So, you know, we all think nerves are kind of thin, delicate things. They're not, they're really quite big. And certainly at the lower down level, at the sacral plexus, where we get the sciatic nerve from, the sciatic nerve is actually about, at its widest, it's about 3 fingers wide. When it's sitting across the top of your buttock underneath your muscles, it's really, really wide. And then when it goes down your leg, it's about the thickness of your thumb. And it's really tough. If you ever get a chance to do practical anatomy with cadavers, have a look. You give it a good tug. It's very, very strong. Surprising how big it is. Okay, so that's the revision done, just to remind you kind of what the structures are that we're looking at. So, what kind of things can cause neuropathy? Well, I thought the best thing to do is to divide this into the different groups, and we'll look at something from each group. So there are often and very commonly physical causes, so that's things like disc problems or compression or trauma. Then there are metabolic issues, so that can be things like vitamin deficiencies, glucose levels. Some drug therapies can cause neuropathies, and we're going to have a look at one in particular, but even common drugs like amiodarone, which is used to manage cardiac arrhythmias, that can cause neuropathies as well, as can methotrexate, and also metronidazole, which is quite a commonly used antibiotic as well. So there are lots of drugs that actually do cause neuropathy if they're used for long enough. And then there are also pathological things like multiple sclerosis or rheumatoid arthritis, diabetes itself. So we're going to choose something from each of these groups, and we're going to have a quick look at those. And the first group we're going to have a look at is the physical group. So anything which can cause direct or indirect damage to a nerve, we would class as a physical factor. And one of the commonest things is compression. And as I said, it can be from clothing, but it can also be from surrounding anatomical structures as well. So that could be that there is joint swelling. It could be that there is edema in an area. It could be there's a foreign body. It could be there's a tumour. Anything that takes up space around the nerve. If anybody's had carpal tunnel syndrome, okay, I'm sure a few of you have had carpal tunnel syndrome, it's quite common. What's happening there is you're getting fluid collecting in the carpal tunnel through which all the nerves run into your hand, and that pressure caused by that fluid will make those nerves not function and your hand will feel numb. Okay, if you lift your arm up and you drain the fluid away, sensation tends to come back. Okay, so anything that causes compression around a nerve can lead to a loss of function of that nerve. Sometimes it's permanent, sometimes it comes back if you take away the pressure. Another cause, which is a little bit more indirect, is ischemia. So if you have a lack of blood supply to an area and a lack of blood supply to a nerve, the nerve won't function. So again, you will lose the function of that nerve as well. And then things like trauma, so things like crushing or splitting or cutting or anything that causes a direct change to the shape of the nerve can cause a problem as well. And the one that's really, really common, and you'll have seen this in your patients, you may even have had this issue yourself, it's so common, is where we have a disc problem. And so a lot of people will call it a prolapsed disc or something like that, but the correct term is radicular syndrome, okay? So a radiculopathy is a pathological change to your disc, to your intervertebral disc, okay? So IV discs, as we all know, sit between the vertebral bodies and their job is to absorb shock, but also to transmit load up and down the vertebral column. So they're there basically as shock absorbers, all right? And they sit between almost all of your vertebral bodies, not quite all, because there isn't one between cervical 1 and cervical 2. They don't actually have that. They actually work on a pinion mechanism, but all the way down, right until we get to L5S1, you've got a vertebral disc, all right? Down at the base, the biggest one is about between 7 to 10 centimeters across, quite big, and it can be about a centimeter thick. It can be up to a centimeter thick. Right up the top in your neck, they're only a few millimeters thick and maybe 2, 3, 4 centimeters across at the most. So they do change, but obviously it's kind of sensible that the lower down it is, the bigger it's going to have to be to deal with all the body weight. Okay, so down at the bottom, these discs are really, really big and thick. And the discs have an outer ring that's quite fibrous in them that we call the annulus fibrosus. And then inside, you've got a soft, pulpy material, which we call the nucleus pulposus. And that's got a very, very high water content. So you've got this outer fibrous bag with the inner pulp. And that means that whatever direction you bend, the pulp inside will move, depend in the opposite direction. And that allows the disc to compress and to transfer weight across the disc and therefore transfer weight across your vertebral body. So it's a very, very effective way of doing things. And they sit, as you can see here, they sit between your vertebral bodies, and the posterior of it just kind of forms the bottom part of the hole that's created between the two vertebral bodies through which the spinal nerve exits. So you can begin to see why this is a problem, can't you? As long as it's nice and normal like that, that's fine. However, if something happens with the disc, we're going to have a problem. And the best way to think of these discs is think of them as jam donuts, all right? So you've got the doughy bit around the outside, you've got the jam donut, the jam in the middle. What happens when you hit a jam donut? It splats out. So if you put too much pressure on a vertebral disc, the jam in the middle, the nucleus pulposus will squirt out. And in some cases, it can come out completely. In some cases, it just causes a bulge of the annulus fibrosus. But either way, if we go back to this diagram here, all right, think about it. This disc is sandwiched between bone, non-movable. There are ligaments running all the way down here and all the way around here, non-movable. The only space for it to go into is here. That's the only free bit. So when any pressure is put on it, that's where it's going to bulge into, okay, where the nerve comes out. So, you know, it's not rocket science, is it? We know what's going to happen. So, as we get older, our discs begin to age, and out of all the musculoskeletal tissues, your discs age faster than anything else, okay? And actually, disc disease can be observed in teenagers. And we know that there's some degeneration begins by the time you're about 10, 11 or 12. By the time we get to about 70, between 60 and 65% of people have disc damage. It's the nature of us standing up. If we were four-legged, it would be different, but because we're bipedal, there is so much pressure put on these discs that they wear out. Okay, and there's some theories about whether it's to do with the water or whether it's to do with your collagen. There are many different theories as to why this happens, but basically they dry up and they thin and they wear out. If the fibrosis bit, if the annulus fibrosis thins and loses its strength, then it's more likely that it will split and allow the pulpy stuff to squirt out. All right, so there's it loses its strength. And in some people, it doesn't happen an awful lot. It's just a little bit of a bulge, and there's enough space in the intervertebral foramen to actually allow the nerve to pass through. But for most people, that's not the case, and the disc will bulge into that space and put pressure on the nerve as it passes through that space. Okay, so you can see here in this one, all right, here's your disc bulging at the back, and it's putting pressure on the nerve as it exits from the vertebral column. Okay, and the most common areas for this to happen are where the spinal column the vertebral column has its greatest curvature. So that's either up in your neck at around about C5 and C6, or down at the bottom where you've got L5 and S1. They are the two areas of greatest danger, because that's where your curvature is the greatest, and that's where your stability is the least strong in your vertebral column. So you can see why you're going to have problems there. So thinking about it, what kind of things do we see in these patients? Well, it's very common. It can be painful, but it can also be numb. You know, patients will describe that painful numbness quite often. It can be tingly. You can lose muscle function, because remember, these spinal nerves are mixed. So not only have you got sensory nerves in there, you've got motor nerves in there as well. So you might lose sensation, but you might also have muscle weakness. Depending on the level of this bulging, you might lose reflexes, particularly if it's down at the level of your L5 and S1, so your L5, S1 disc in there. You could lose your ankle reflex. Okay? If it's much higher up, about L3, L4, you could lose your knee reflex. So it will depend on the level where this happens as to what specific things you are going to see. But on the whole, you're going to lose sensation, you're going to lose potential motor function, and if it's higher up in the vertebral column, where the nerves exit the control gastric function or sexual function, you could lose those as well, because the autonomic aspect of the nerve can be compromised too. So you sometimes can get interference with gut function as well if it's happening perhaps higher up in the vertebral column, maybe about the lower thoracic level rather than in the lumbar level. So it can be incredibly painful for individuals, and as we all know, it's not helped by moving about. Some compression syndromes are helped by moving about. It's not particularly helped by moving about. So there's an awful lot of discussion about the best way to manage disc problems. A lot of patients end up having surgery. My husband's just recently had decompression surgery in his lower back for a disc problem, and also some in his neck as well. And the difference has been incredible. He used to be able, if ever we're going shopping, and now I think about it, maybe it wasn't the disc, I don't know. But whenever we were going shopping, he would say, "Oh, I have to sit down. I can't manage this. My legs have gone to sleep. My legs have gone numb." And part of me would think, yeah, you just don't want to go shopping. Because, really, there was an issue. When I looked at his MRI, I thought, oh, God, yeah. Maybe you need to be a bit sympathetic. Maybe not, I don't know. But it's gone. The pain has completely gone, which is amazing. Really, really good. So surgery can be very, very effective. But of course, if you've got a disc issue and you are seeing symptoms in the lower limb, we can easily work out what level the disc is, because remember, that's why we learn about dermatomes, and I'm not going to do dermatomes, but just to remind you that, remember, if you understand which part of the limb is supplied by which spinal nerve, you can roughly work out where the level of the disc problem is by looking at the clinical symptoms, okay? So just bear in mind that you can usually work it out simply by looking at your clinical signs. What else do we need to say? I think we've kind of said mostly about that. Oh, one other thing I want to say about compression problems around here is a lot of patients will also have something called piriformis syndrome. which you might have come across. And this is also a compression thing. So not only have you possibly got vertebral disc problems, but if you have any kind of swelling or damage in the muscles around the buttock, okay, in the posterior of your pelvis, you're potentially going to get compression on the sciatic nerve, and the sciatic nerve exits the buttock by emerging below your piriformis muscle, and then it sits on top of your gemelli and your obturator internus. So there's your gemelli there, there's the inferior one, superior one, and then you've got your obturator internus down the middle. And if there's any swelling, either here or here, that will put compression on the nerve, and that's very commonly seen in a lot of people. This is the one where if you sit on the floor and stretch out your buttock muscle, you really pull and stretch it, the pain goes away. If that's what's happening, you've probably got piriformis syndrome. Very, very common. And people just assume it's, sciatica. Well, sciatica is just a descriptive term. Sciatica is pain in the sciatic nerve. It's the cause that you need to think about. And mostly, or very commonly, it's piriformis syndrome. Okay. The last couple of things we're going to look at for physical before we move on to something else is also bear in mind that a lot of patients do get osteoarthritis in their vertebral column, and any kind of change to the surface of the bone can cause disc problems, but can also cause problems in the intervertebral foramen as well. So say you get osteoarthritis and some little extra bony formations in the space or at the edges of the bones here, again, that's going to put compression on your spinal nerves as well. Okay, so that's spondylosis. We call that spondylosis, where you get osteoarthritic change to the vertebral bodies. You can also get what we call stenosis, and that is a stiffening as well of the soft tissues around the vertebral bodies. And if they stiffen and thicken, they can also put pressure on the emerging nerves as well. So anything that puts pressure on is going to cause a neuropathy. Okay? Right, we're going to move on to the next group, which are the metabolic causes. All right, and we're only going to look at a couple of things here. But any change to the biochemistry of your body, whether it's in your tissues or whether it's in your blood, will have a direct effect on nerve function. And it either can be because the things that are needed to maintain the nerves being healthy and functioning correctly are missing, or it could be that there is a change in the chemical pathway of how that nerve functions. So it can either be something that actually damages the nerve physically because of a lack of it, or it could be something that damages the nerve physically because there's too much of it. Okay, and the commonest examples to think about are vitamin deficiencies and the role of glucose in this as well. So two common vitamins that are really important for nerve function are vitamin B1 and B12. So thiamine is B1 and cyanocobalamin, which is B12, and they are essential for normal nerve function. And a lot of people are deficient, particularly in B1. It's not uncommon, and particularly patients with diabetes. Type 2 diabetes, almost all have thiamine deficiency. So there's a lot of research about should patients with type 2 diabetes be taking thiamine supplementation anyway. A lot of interesting research about that, something to think about. So we'll have a look at that first, okay? So we know that vitamins are hugely important for nerve function, and the B ones really are at the forefront of this. These vitamins are important for the production of energy, so they work very closely with the energy producing factors in your cells to actually release energy so that your cells can use them. And that becomes really important for energy coming from carbohydrates like glucose, because your nervous system can only get energy from glucose. It can't utilize energy created by proteins or fats because nerve cells just can't process them. So nerve cells and your brain only get energy from glucose, okay? Only from glucose, which is why if you have a glucose deficiency, your brain function will change very quickly, okay? Can't utilize proteins and fats, only glucose, right? Okay. So let's have a quick look at thiamine. Like I said, very, very commonly seen to be deficient in many patients. And it's really, really essential for utilizing carbohydrates to produce energy. If you don't have thiamine and you have a long-term deficiency, that produces something called Wernicke-Korsakoff syndrome or Wernicke-Korsakoff encephalopathy. Now, most of us think of this purely in terms of the underlying cause, and the commonest cause in the Western world is alcohol abuse. Okay, which is why most people think Wernicke-Korsakoff syndrome only happens in people with alcohol problems. It doesn't. It happens in anybody who is long-term thiamine deficient. But the commonest cause of that is alcohol use. Okay, and that's because excessive alcohol intake stops you absorbing the B vitamins in your gut. All right, your diet is poor, you can't absorb the vitamins, and your body only takes about 3 months worth of thiamine into storage. So once you've used that store up, that's it. It's gone unless you replenish it. And if you've got an alcohol problem and you're drinking regularly, you will not be able to replace that thiamine. No matter how much you put it in your diet, your gut will not absorb it. Okay? So we know that more than 80% of people with Wernicke-Korsakoff syndrome have a polyneuropathy. And what that means is it affects the motor, sensory, and autonomic systems, all of them. Okay? So nothing escapes, everything is affected. All right? And usually, once it's gone, it's gone. Okay? So once you've got Wernicke-Korsakoff syndrome, it's very difficult to get that function back. We also know, as I said before, that a lot of patients with type 2 diabetes have thiamine deficiency. And it's thought to be, one, a combination of gut problems. So we know that the gut microbiome actually is far, far more important for understanding what happens in type 2 diabetes than we ever realized. So the gut microflora are important. It means that you can't absorb your thiamine effectively. And patients who are on metformin are almost always thiamine deficient because the metformin interferes with thiamine absorption. So again, there's a lot of discussion about if you're on metformin, should you be taking B1? And you know, the idea behind it now is that you probably should be, because if you take more in your diet, you've got more chance of absorbing some of it. Even if you don't absorb a lot, you've got a better chance of absorbing some of it. Okay. Also, with the increase in gastric surgery now, that's creating problems because if you lose some length of your gut, then your ability to absorb thiamine or anything at all is going to go down as well. So there's a lot of controversy about gastric surgery in terms of its role in vitamin deficiencies as well. So, you know, bear in mind that if you've got a patient who's had gastric surgery, they may actually be thiamine deficient. They may be at risk of developing a neuropathy as well. Okay, and also anybody who's got kidney disease, your thiamine, all the B vitamins are water soluble, and that means that you will basically wee them away. And what your kidney does is, as the filtrate in your kidney goes through the kidney tube, you want to remember how everything, all the important stuff gets reabsorbed. Well, your vitamins, your B vitamins get reabsorbed in your kidney. Okay, if your kidney's not working properly, they won't get reabsorbed and you'll just pee them away. All right. That's why when you take water-soluble vitamins as a supplementation and you don't need them, they just go straight down the toilet. Okay, but you know, the fat-soluble ones don't. They're dealt with in a different way. But the water-soluble ones, you'll wee them away if your kidneys don't actually reabsorb them back in. So if you've got kidney dysfunction, you've got an issue. And if you're diabetic, what happens to your kidneys in diabetes? Your kidneys have the same problem as the nerves do. They are damaged very, very quickly, kidney cells, so it could be that you are also renally deficient as well, and then you're going to lose your levels of thiamine. Looking at cyanocobalamin, which is B12, essential for different reasons. So B12 is really, really important for maintaining the health and function of types of cells which support your nerves. So you've got a group of cells called glial cells and oligodendrites, and they basically make sure your nerve cells, your neurons, function properly. They look after them. And we know that B12 is essential for those supporting cells to maintain their own function. So if you don't have B12, your glial cells and your oligodendrites can actually die, which means that your neurons aren't supported, your neurons aren't monitored, and therefore your neurons won't function as effectively. We also know that B12 is essential for the production of myelin. Think back to the slide earlier on where we looked at the Schwann cells and the myelin surrounding the Schwann cells. If you've got no myelin, what's going to happen to nerve conduction? It's going to get reduced because you've lost that insulating beneficial effect. And so you need really good, healthy population of Schwann cells full of myelin to get the nerve to function effectively. So if you haven't got it, if you haven't got the myelin, then your nerve cells aren't going to function. Think of think of a well-known disorder where myelin is destroyed, like multiple sclerosis, which we'll look at shortly. That just goes to show you exactly how important the myelin is. If the myelin goes, the nerves don't function, and you're going to have a neuropathy of some sort. Okay? The reason that you tend to be deficient is usually because of some underlying problem with absorbing B12 in your gut. And it's usually because you're lacking something called intrinsic factor. And that's kind of the underlying problem with pernicious anemia, which is an autoimmune disorder. But interestingly, it can also occur because of drug therapies. So L-DOPA therapy for Parkinson's, well known for causing problems in B12 absorption. Again, gastric surgery for the reasons that we spoke of before. But this is an interesting group, the proton pump inhibitors. Okay, omeprazole, lansoprazole, they all interfere with B12 absorption. How common are they? Very common. Anybody taking a long-term non-steroidal drug will be on a proton pump inhibitor as well. They should be. So you can understand why that becomes a problem too. All right? Okay, and the last one we're going to look at in this particular group is the role of glucose. It's important to remember that neurons, their sole supply of energy is glucose, but neurons don't need insulin to take glucose in. Remember, we're taught that cells in the body require insulin to take in glucose to use for energy. Well, there are some cells don't. Some cells, doesn't matter how much insulin you've got, doesn't matter, because they will take glucose in anyway, irrespective of insulin. And those cells are your nerves. And there are two others that are the same. They are your kidneys and your eyes, which is why you get the combination of neuropathy, retinopathy, and nephropathy, because those cells don't need insulin. So the higher the levels of glucose in your blood, the more glucose those cells will take in an uncontrolled way. All right? That creates major problems, because how your cells, particularly your nerve cells, deal with glucose is they put it through their normal pathway to produce energy. Any extra glucose goes into a different biochemical pathway, which we call the polyol pathway, and that then allows the glucose to be broken down into sorbitol, and the sorbitol is then used to produce energy. So on the whole, the cells cope with it. If there is too much glucose, you get too much sorbitol. Sorbitol damages nerve cells. So the more glucose that you have taken into the nerve cell, the more sorbitol you get produced, the more damage is done to the nerve cell. And the same happens in the kidney cells, and the same happens in the retinal cells as well. So that's the pathway there. You don't need to remember it. But basically, any glucose that isn't used directly for energy is broken down by an enzyme to produce sorbitol. That's then broken down by another enzyme and goes on to produce energy. Okay? Now, nerve cells, all your cells, have a very limited supply of this. Once it's used up, it takes that cell a long time to produce some more. In the meantime, this builds up and builds up and builds up and eventually damages the cell. It can even kill the cell off. Okay? So this is why uncontrolled levels of glucose in the blood, hyperglycemia, directly damage nerve cells and lead to neuropathy. Okay? When you think about it like that, it makes absolute sense. All right? But this is one of the reasons why we say to patients, you must keep your blood glucose levels at the right point, because long-term glucose, long-term hyperglycemia is going to cause you nerve damage, and it's going to cause damage in those particular cell groups first: nerves, eyes, kidney, because you don't need insulin. Okay, right, moving on to the last two groups, which we're going to get through quite quickly. Before I forget, just to finish this bit off about glucose, the other thing about high levels of glucose is that those glucose molecules attach to proteins in your tissues, in your blood. The more glucose you have, the faster they attach, and particularly they like to attach to collagen. And the collagen in your blood vessels is a real target for this, because it's easily accessed by the blood glucose, and so the collagen itself becomes stiff. That stiffens the vessel walls, which means that you actually get less blood being supplied. You get these vessels functioning less effectively, and so because of that, you become ischemic, and because of that, you become neuropathic, because you've got a lack of blood supply to the nerves. So not only have you got the direct effect of glucose on the nerve cells, you've got an indirect effect, because ultimately you'll end up with ischemic change that will impact on your nerve supply as well. Hopefully that makes sense. Okay, right. So last couple of things to look at. We've got two groups left to look at: pathological change, pathological factors, and drug factors. So we're doing okay for time. So a whole range of pathologies can cause neuropathy and neuropathic change. There's so many of them. But the ones that we're going to look at, well, the only one we're going to look at is multiple sclerosis. I mentioned polio on here because, interestingly enough, just this year, I don't know whether you saw anything in the news, but the polio virus has been identified in sewage at much higher levels, particularly down here near London in the southeast, not so much further north, but it's interesting that suddenly virus levels seem to be shooting up. Nobody really knows what's going on there, but worth just keeping an eye on that one, I think, because you never know what's going to happen with that. But with multiple sclerosis, this is where you get a loss of myelin throughout the neurological system, and it isn't always in a uniform way. So you get this patchy loss of myelin, and whether we have family members, friends, ourselves, or patients, we know that with multiple sclerosis, there is this unusual loss of nerve function in lots of different tissues. So it could be a change in sight, it could be a change in talking, it could be a change in movement, it could be a change in sensation, it could be in the gut. There's a whole range of symptoms that we see, and it's all because the myelin is destroyed, and there is an underlying autoimmune issue going on here. Whether what it's caused by, nobody really knows. It could be something to do with environmental factors, it could be genetic, but the biggest guess at the minute is that it's viral. There is some underlying viral cause that, for susceptible individuals, leads to an autoimmune process being kicked off, which then ultimately leads to the destruction of myelin around the nerve cells. So viruses seem to be the key thing here. And basically what happens is this autoimmune process kicks off inflammation in the neurological system, and that inflammation basically leads to the death of nerve cells, or the death of the Schwann cells, and therefore you're losing your levels of myelin. And sometimes that inflammation can settle down and everything goes back to normal, which is why with MS it can kind of come and go. But sometimes what happens is that you actually get fibrosis forming where the inflammation has been. So you can get these fibrous plaques forming in the neurological system, often in the brain. And so that damage there is permanent, and that whatever was controlled by that area of tissue, that function is lost. But again, the underlying mechanism isn't really clear. And there is some new research that actually says that the death of the cells can come before the inflammatory process even occurs, and it's actually the effect of a virus that's doing it. That's very controversial at the minute, and it's very new research, and the work that was done has not been done on a big enough group, but that's something interesting, I think, that is maybe worth, if it's something you're interested in, keeping an eye out on. So, as I said before, it's the myelin that gets damaged. Once that's gone, it can't really be replaced, and the nerve can't be repaired, and so therefore you're going to end up with this loss of sensation. And a lot of patients will also, as well as a loss of sensation, they'll complain of neuropathic pain, a little bit like diabetic painful neuropathy. So whilst there is a lack of sensory function, it's also painful. The burning, the tingling, keeping them awake at night, it's very, very uncomfortable. So a lot of patients with MS will complain of that kind of pain. So I'm sure you've come across that in some of your patients. And in terms of what happens in the brain, this is a scan of somebody with MS, and the pink bits basically are the sclerotic plaques in the brain where that tissue has basically died. and it's become sclerosed, and those bits of the brain won't function anymore. So you can see it can happen in lots of different parts of the brain. And that is permanent. So the end result of this, of course, is that loss of neuron function. So whether it's motor function or sensation, you know, a lot of patients will complain of problems talking. Their sight is often affected, and very commonly they get autonomic dysfunction as well, so they may have trouble with their gut function too. A lot of people with MS have digestive problems because it's the autonomic system that's affected as well. So it becomes really problematic for these individuals. But as you'll know, if you've got any patients or friends or family with MS, it can come and go. And there are lots of different types of MS. So some patients will go a whole lifetime with MS with only kind of minor disability, whereas some in a matter of months can go to quite significant disability very, very quickly. So it will depend on the pattern for each individual. And the last thing to look at before we finish is just, again, to remind ourselves about the drug therapies. There's a list of some examples, but there are a lot more. But one thing just worth mentioning is there's a particular group of drugs, the chemotherapy drugs, which actually are well known for producing neuropathies. So any patients that you've had who've been on chemotherapy at some point may well have a chemotherapy-induced neuropathy. And the estimate is about 80% of patients who've had chemotherapy, will have some level of neuropathy. And for some of them, it lasts forever. Okay, so whilst they're having the chemotherapy, about 80% will show neuropathic change. Once chemotherapy is finished, about 50% of patients will have permanent long-term neuropathic change. And it's something that I wasn't aware of till a few years ago. So, you know, bear in mind that it's the same kind of presentation as painful diabetic neuropathy. So it's that pain, tingling, electric sensations. You know, sometimes there's loss of motor function, but it's mainly sensory for these individuals. So just bear in mind that if your patient's had chemo, you're going to need to think of them as a bit of a high risk continuously, even if the chemo is finished, simply because of the neuropathy that goes with it. Some of you may have come across that in patients already. So, pulling everything together then. We know that neuropathy's got lots and lots of different causes, hundreds and hundreds of different causes. They mainly fall into the categories of physical, metabolic, pathological, and drug-induced, right? But within that, there are hundreds and hundreds of reasons that it can happen. It's always because the nerve isn't functioning for whatever reason. It's either damaged or something's interfering with its pathways of transmitting its action potentials. And as I said, the causes are numerous, but whatever the cause, that loss of function creates problems for clinical management, because you then have to think about, okay, what is it that's missing that is going to be something that I need to worry about? And particularly with loss of sensation, you know, what does your patient need to watch out for? What do you need to watch out for? What do you need to advise them? So really, you know, your clinical assessment becomes very, very important for these individuals, because you can possibly identify that there's neuropathy that the patient didn't even know about. How many of us have come across patients who've had something in their shoe that they didn't feel? You know, I remember having a patient with diabetes who had a piece of glass in his shoe, and he had this ulcer when he came in, and he said, I just don't know how it happened. And I looked in his shoe and there was a piece of glass, and I thought, how can you not know? But he didn't, because he was neuropathic. So in your role, in your profession, it's a really, really important area to understand of how it happens, how it presents, and what you can do. So that has been a very, very fast run through of neuropathy. We've kind of done the headlines, okay? Some of you may be feeling a little bit like this now, kind of sitting upright and thinking, oh, I need my lunch, okay? Some of you may have mastered the art of sitting in a chair looking awake. If you have, well done, because I can't see anybody asleep. But yes, so thank you for your attention. If you've got any questions, happy to take them.